Today I'm going to talk to you about terrorism response. I suppose when we talk about this, I've tried to steer it towards how it's relevant to yourselves from in and pre-hospital trauma providers. Just to give you kind of an idea from people we've spoken to internationally, from conferences I've been at in relation to sort of modern day terrorist incidents that have occurred, and lessons that would be useful for yourselves and ourselves, obviously, in relation to how sort of trauma or how terrorism affects both the in and pre-hospital, the medical and the police end of things, nowadays more so than it used to. And I suppose the synopsis, the spoiler in all this is basically the medics have to take on a more frontline role, generally speaking, and also the police have to take on a more medical role, is generally where you find things are going, the lines start to blur. This is a gratuitous photograph of myself with Anderson, who's a FARC rebel leader over in Colombia. We visited there with the president in February, and obviously the best terrorism response is exactly this, to talk to the terrorists, come to an arrangement and stop them killing you. But so they have a fantastic system over there, and it's going, I'm optimistic that it's going very well for them. But unfortunately, as sure as one, you solve one terrorist problem, another one pops up, and we've seen the new ones are somehow more, sometimes more vicious, sometimes more innovative in the way there's never any end to the innovation that terrorists have trying to kill people. So if we think back to our own, we see the difference here between what we used to expect from a terrorist incident and what we do now. So in the old days, somebody puts a bomb on the bus, the bomb goes off. So the bus then is just essentially a major incident scene. But the danger to people in terms of what might be in the bomb was not really there. Nobody expected there might be sarin gas, or nobody expected there could be anything nefarious. And then with the London bombings, it was the sort of close to home, but it was the first time that we sort of see that the terrorists, or not the first time, but it was one of the times that brought home the fact that the terrorists now want to kill themselves. And if you look at the recent incident in London with the car on the bridge, so firstly they try to kill as many people as they can, and then when they're done, they get out and they try to kill some more people. So as it turned out, unfortunately, the first responders there, the policeman was killed. It could just as easily be a medical responder or someone like that. So what we used to know as terrorism, nice and simple, a bomb goes off, you go in and save people, that's not as clear cut anymore. And now we might have several waves of the attack to deal with. So where are we from an Irish point of view? So all over the country we have regional support units. These support units are all trained up to emergency first responder BTEC, which is basic tactical emergency care, which is a level that was brought in specifically for after we made a presentation to FEC, and they were fantastic about taking the ball and running with it. So it's effectively for exactly these situations where an EFR might have to put on a tourniquet, you may have to use a hemostat to save somebody's life. So now if you have this EFR BTEC module, you can now use these things in areas where the likelihood of you getting say an ambulance support to come in or be there in a timely fashion is low because of the danger or the time constraints. You can do it yourself. Also, ERU have EFR, BTEC and EMT BTEC people, and again, same idea. If there's multiple casualties, or if because of the location, the danger, whatever it might be, for argument's sake, an ERU EMT can put on a tourniquet, use a hemostat and so on. We have an ad hoc integration with a tactical emergency medical support. We have rolled it out on a sort of a case-by-case basis, and the next step is for us to sort of formulate that, and hence the deeper integration is planned. And I know one of the guys that's working on it was at a lecture recently in relation to the Bataclan, which we'll deal with later on. But again, that would appear to offer the current, what I would consider at least, the current gold standard approach of integration for the potential incidents that we're coming across all around Europe and the world. So, different examples I'm going to refer to. These are not by any means an exhaustive list of terrorist incidents, but there just happen to be ones where I've spoken to people about them and they have lessons to teach us from it. So the Aurora cinema shooting. One thing, aside from the general mass casualty nature of this and the fact it was an active shooter, one of the things that the medics told us over at ASAP was that a lot of the casualties arrived by police car. So not a big deal, you would say, if somebody rocks up to the emergency department, having been stabbed down outside the American embassy, gets wheeled up here, everyone knocks on the door, says, listen, we have somebody's after getting stabbed. You come out, you go, oh, you should have told us, no problem, get 2 or 3 colleagues together, and that's fine. When that happens, if there's, say, 10, 15 casualties, the problem is that the police are fantastic people. Disclaimer, bias. But the fact is that they'll take on things and they'll get stuff done. There's studies there to show that police bringing people to hospital has, at least as good a chance of survival, if not better, because they just take immediate action to get them there. The problem arises when you have a mass casualties situation. You don't get that element of warning where you can sort of properly plan your staffing. You don't get a say over whether you should divert people to go to James's instead of Vincent's or so on. So that's one thing to be careful of. I don't see it being solved anytime soon. So if there is a mass casualty event and there's a load of police cars go there, say a car was ploughed down Grafton Street for argument's sake, you may find, or if there was a load of people stabbed more so, you may find that the guards will throw people into the car and they'll flake off to the nearest hospital. A noble thing to do, but it will give you a more chaotic arrival, whereas if it was a load of ambulances, you'll probably get a heads up as they arrive, and somebody will put some bit of shape on who's going where. In Orlando then, a couple of things to note as well. This was the nightclub shooting, and you can see here, this is obviously the building it happened. This is one of the police responders. Helmet earned its keep that day, and I think he did get injured, but the helmet took the harm out of it on the way through. There was a couple of things there. So years ago, when you had somebody took somebody hostage, it was an old-fashioned, say, hostage taken, as it were. If you look at, say, the likes of the planes on 9/11, what used to happen when someone hijacked a plane, you'd fly to Lebanon, you'd be on the tarmac for a few days, there'd be negotiations, and then you go home, or whatever else. Nobody ever thought that a plane was going to fly into a building. Similarly to people being taken hostage, the problem is that if you try to negotiate with these people, you have currently injured people that are bleeding out inside. You have people who may be further injured. So generally the difference from a policing point of view for these type of things is that once they start an active shooter, you're better to keep it going as an active shooter and not to then transfer into a negotiation role, because people are dying while you're talking. So that's a sort of a learning point from our point of view. In Orlando, there was a major trauma centre 3 blocks away. There was a couple of different points that were discussed over at ASAP as well, but this was a kind of an interesting one. They had various surges, but the first was an influx of people presenting at the hospital looking for treatment, information or shelter as a result of the disaster. So people say, what will we do? Let's go to hospital, see maybe they can help us out. So they're just going to present. Some of them need medical treatment, some don't need urgent medical treatment, some just want information. And one of the things that they said was communicate in 6th grade language. So give very simple communications, because people are confused, people are hyper, and you need to communicate in elementary language to these people. And then the second thing, and again this would be hugely relevant to yourselves, is that you get a disaster surge. So the issue is that if you're a couple of blocks away, so if someone is stabbed down at the American, or say loads of people are stabbed at the American embassy, half of them will get into taxis, half of them will hobble up to Vincent's, and then all of a sudden you'll have all your beds full of these people who have, relatively, in the circumstances, relatively minor injuries, or they might on another day be a relatively serious injury, but next thing you could get another 15 people arrive up who really need your help, but all your resus bays and everything else is filled with these people. So just be careful on incidents like this. It may well be, could be the police that are bringing them up if you combine the last problem with the current one. Maybe the police arrive up with all these people, half them are you know, on the outside, not too badly injured, but when they get into the meat and potato of it, in the actual, you know, epicenter where it's going on, the problem is that the really injured people are coming next, and, you know, you have to make sure that you have the capacity to take them when they arrive as well. Okay, the Dallas police shooting then was one where the shooter specifically targeted the Dallas police, and it's the one you may recall where it was ended by a robot with explosives on the end because it was so dangerous. They didn't want to send in risk any more police lives. So one of the lessons that they learned over there, and again it's probably a more American thing, but I think it's definitely the way forward, and around Europe people are doing it quite a bit. The officers were pinned down because of the nature of the weaponry that was used against them. And apparently the pre-hospital tactical doctors were vital to it. So obviously police medics can do a certain amount, but obviously you need paramedics. Over there was a doctor talking, so they were talking about doctors, but tactically trained, like the heart team, say in the UK or whatever it would be, you have more advanced medical care, advanced paramedic level, I would envisage it, who can go into the scene, take on a little bit of extra risk, but can provide treatment where a patient can't be readily moved in a normal fashion out to an ambulance and so on. And I think all over the world with the modern day sort of terrorism, the general feeling is that EMS and police both must assume an enhanced risk. Now, not everybody would agree with this, but if you look at what used to be the protocol generally worldwide, if somebody runs into a building with a gun, again, it was an old-fashioned hostage taking, so you call SWAT, call negotiators, call all these people, put a big thing in place and corral the situation. The problem is that that type of an incident then turned into an active shooter situation. So they have what I now call the call your mother and tell her you love her and get in and do something about it sort of technique, which is basically the first person on the scene, whether it's a local detective with a pistol, whether it's a uniformed cop, whatever it is, if there's an active shooter going on, notwithstanding the fact that you don't have the best protection, you don't have the best weapons, you don't have the best training, but the thing is that you just go in and you do your best because there's people getting shot as you're there. So that's a fairly dramatic change from the way things were. It was all about safety and get all the shields and get all the training and all this. So things have moved on a little. So where are we going, hopefully? And this is a sort of a model for how I would see where we should be, because again, we haven't thankfully had a big terrorist incident, but we would be naive to think that it couldn't happen tomorrow, because all you need nowadays is the keys of a truck and you're a terrorist, you know. And if you decide today that you're going to hijack a truck, or you have a truck and you're going to drive it in somewhere into a load of people, if you haven't communicated it to a lot of people, it's very hard for anybody to know what's coming. So I think we should have preparations for when the inevitable like this would happen. So the Bataclan in Paris was a really interesting, it was a horrendous case obviously, but it was really interesting from various points of view. You can see here on this shield, this is a ballistic shield which has taken, I think it was 25 assault rifle rounds, and there was guys hiding behind that shield while after the initial wave downstairs, it then turned into a barricaded situation upstairs. But the guys behind that were, no doubt about it, their lives were saved by the shield. The other thing about it is that downstairs, while all this was going on, there was treatment going on here for all the many and various injured that were therein. So a couple of things in relation to it. There was doctors embedded with the police response units. So obviously they didn't just turn out that day, they had comprehensive training, comprehensively equipped for the task at hand. Crucially, which would be relevant to us and would be outrageous to Americans, that none of the docs or the medics were armed. They were just protected and equipped but not armed. They had obviously trained with the units for some time. A couple of things where they proved very useful was critical triage within the theatre, as in within the downstairs area that you could see where all the people were critically injured. By all accounts, there was some decisions made where guys were picking up people who they thought were healthy. The docs were telling them to put them down, and when they take somebody else and they come back, the person was dead. So it's that split-second sort of, critical triage when they're deciding who to bring out. They set up a field hospital and a dressing station just outside. Interestingly, contrary to, there was a study recently that said that there was no sort of battlefield injuries, or it was mainly chest and head trauma, I think, in all these terrorist incidents. Well, interestingly, there was 15 tourniquets and 15 hemostats were used within the Bataclan to save lives. So it would appear to go, I know that was a controversial paper, but it would appear to go against that. Obviously, morphine then and TXA was used fairly comprehensively. And interestingly then, no regular medics were allowed into the scene, as in no responding ambulances or whatever were allowed into the scene until the scene was cleared from IEDs. But by that stage, all the triaging and evacuation of patients had been done. So the responding team had 5 doctors embedded with them at that point. I know of other units around Europe where they have policemen that have become doctors, they've doctors that have become police people, and it seems to be a sort of a trend that they have where they're integrating on a more deep level than before the two sort of roles. And certainly, if not fully there, but I would certainly see that where we need to go for sure is to sort of have a much closer integration between the ambulance service, between pre-hospital doctors and ourselves, where you can turn out a team for an incident such as this, and if you're pinned down for a period of time with a lot of injured people, that you can start some of the vital life-saving interventions while there's still an element of danger there in that warm zone, because there's people's lives at stake, and every bit as important as fighting the fight for the ongoing barricaded incident or whatever is commencing the life-saving, the triaging and the evacuation of people who can be saved, and equally as importantly the abandoning of people who can't, so as you're not wasting your resources in difficult situations. So the other thing from the Bataclan, danger may be present when the treatment begins. And another thing that we learned from a separate incident in Belgium, and it was actually the police themselves had the learning point. They were involved in a shootout in a sort of an apartment building. But the one thing that they forgot was their earmuffs. And when the whole thing was going on, they couldn't hear themselves talk. So another thing, quite likely, if it was a bomb or anywhere there was a lot of gunfire, as you get people presenting to you, there's a good chance, like the movie Heat, where he asked the guy the question, they just won't be able to hear you. So that was another learning point. Once the gunfire started, they were completely deafened and had great difficulty communicating. So that could be relevant to your triage or decision making thereafter. One more thing, try to secure your emergency department. These days, we don't know. I do know of a doc when he worked in London that somebody tried to kill somebody else, and while they were treating him in resus, they came into the hospital looking for him again to finish him off, but went into every room except resus, thankfully. So it's not unheard of. If I was you, I'd try to get some arm protection up to protect the ED. Maybe a big ask, but I think it's probably something that would be useful to do. Because there's no point in if it's all going on down there, the way things go these days, there's nothing to say that they wouldn't try to follow up thereafter. So that's all I have. I can cram into 20 minutes. Hopefully it's useful. I'm happy to take any questions that anyone has.
Thank you very much.